Good morning. My name is Ryan Griffo, and this is Health and Wellness. We are fortunate enough to have Dr. Bruce Malkowicz, the co-director of the Urological Oncology Program and the Thomas D. Stitcher Memorial Professor in the Urological Research at Penn Medicine. Today we'll be talking with Dr. Malkowicz about the newest treatment approaches for patients with prostate cancer. Doctor, thank you for being here with us. My first question for you is, how do you determine if a patient has prostate cancer?
Generally and classically, we've determined prostate cancer by following up on an elevated PSA. Before PSA, it was really a question of patient symptoms or problems with urination. But for the most part, the diagnosis of prostate cancer has come from a laboratory test because there really aren't that many symptoms. Classic problems like issues with urination and other things do not mean that you have prostate cancer, because the vast majority of people with voiding dysfunction don't. So what we've been challenged with is actually finding more discrete ways to detect prostate cancer, because just screening everybody with a PSA is ineffective, and that's been shown over the past couple of years. Generally, patients have to enter into a dialogue with their physician about their concerns regarding prostate disease, and then discussing the pluses and minuses and the merits of getting a test, and then pursuing that from that point on. When you have suspicious findings, then you go on to a needle biopsy of the prostate, which is generally done under local anesthesia. A pathologist then evaluates that tissue, and then that gives us a more definitive picture of whether somebody has disease or not.
That's very interesting. Now, is there any way a man can prevent getting prostate cancer?
You know, that's an excellent question, and millions of dollars have been spent on that. But unfortunately today, I can't say there's an absolute foolproof way that you can help prevent prostate cancer. Many times we talk about diet and saying that maybe a diet lower in fat may be helpful. But I can't say reducing your diet by X amount of grams of fat will decrease your risk of prostate cancer by Y%. We've also looked at either medications or even vitamin and mineral supplementations, and there's been mixed results with these studies, even though they've been very large studies, very large studies that have been supported by the government.
Very interesting.
Yeah.
And now, what are some current treatments that are being used for patients with prostate cancer?
Well, I think one of the biggest issues is that one of the first things that we're considering is no treatment at all. That doesn't mean just telling a person that they're fine, that this won't hurt them, and sending them on their way. It's been noted that a lot of prostate tumors are kind of indolent in their behavior. People who we've done radiation on, we've operated on, and we've followed them for 15, 20 years, we see they do amazingly well, and then it brings up the question, did we really need to treat these people that aggressively to begin with? And then programs of doing biopsies, checking PSAs, doing examinations, and monitoring people shows that people can stay on a program like that. Maybe about a third of them may go off that type of a surveillance after a couple of years. And the good news is that those people who decide to get treated several years further down the line, because either there's been a change in their biopsies or their PSA levels going up, or they've just gotten tired of this program, that their outcomes are almost exactly the same as those folks who got treated at their initial diagnosis. So, you know, the take-home message is that there's a good, solid cohort of people who are diagnosed with prostate cancer who are not going to go on to something like radical surgery or radiation therapy. That being said, those are the two most common forms of treatment for what we call clinically significant disease. And radical prostatectomy was really refined in the mid-1980s, and a large body of experience was accumulated over about the next 25 years. We're fortunate in that the introduction of minimally invasive techniques also became well adapted for prostate surgery, and there's a lot of folks who've worked on things like robotically assisted laparoscopic prostatectomy that don't change things that much in terms of the big outcomes and side effects, but can reduce some issues in terms of the time to recover from such a procedure and issues like blood loss. The other very useful and well-defined form of therapy is radiation therapy. And there the technology has just continued to improve over the past several decades, and there are several different options within the radiation oncology world that offer excellent therapeutic treatment and outcomes for patients. Beyond that, you start getting into the realm of true medical oncology, and there have been some interesting breakthroughs there in terms of earlier use of chemotherapy in patients who have advanced disease, and the classic form of hormonal manipulation, because prostate tissue is uniquely male tissue. It responds to male hormones. Someone won the Nobel Prize for work done in the 1940s and the 1960s on that. And it's been so impressive that that's still been the central pillar of therapy for advanced prostate cancer. But newer findings and the use of targeted agents are coming into play as well.
Oh, that's very interesting. And Dr. Malkowicz, if you don't mind telling our audience as well, what are some of the common patient concerns for patients who do have prostate cancer?
Sure. I mean, when you get a diagnosis of prostate cancer, obviously the first concern is, oh my God, what is the intensity of this disease? Is this going to have an immediate effect on me? Is my life going to be horribly shortened very quickly? And in most cases, that is not the case. And there are, as I said, with many people are in just a surveillance program rather than active therapy. And then for those people facing defined therapies like surgery or radiation, the next question is, well, how long is this going to take? How is this going to take a chunk out of my life? And what type of long-term side effects can I have from this? The long-term side effect issues that we usually look at with surgery, because in most cases surgery is well tolerated. Not all surgery has its risks, but in general most people will do well. But in long term, the issue that people are looking at most, and the most unique and significant issue with surgery, is the small but real potential for permanent urinary incontinence. And for those people who do high volumes of surgery, that number is roughly in a sort of 3 to 7% range. Also, there are problems with sexual dysfunction, and that's a very age-related issue. Things like nerve-sparing surgery can work well in younger patients, a little bit less well in those patients as you start approaching or go beyond age 70. But there are many ways to restore sexual function. Sexual function is also affected at a slower rate by radiation therapy, but I think it's important for the doctors to say that we're not talking about the end of sexual function, the abrogation of sexual issues, but things do change, and there are many forms of medications and therapies to restore function. And I usually tell people, we'll put this on the shelf for a while, treat your disease, and then, we have folks who are experts, within our department who can address these issues for you. With surgery, the issues, as I said, are with the urinary incontinence. A unique issue that comes up more with radiation therapy patients is the fact that the prostate is right by the rectum, and a little bit of full-dose radiation has to be absorbed by a portion of the rectum, even with the modern techniques we have then, and there's a slight risk for some long-term lower bowel dysfunction that has to be addressed as well.
Absolutely.
Again, in that small range of about 3 to 7%.
Yeah. And a follow-up question to that, we just talked about some of the patient concerns. Now, as the physician, how do you deal with the families of these patients who have been diagnosed with prostate cancer?
Well, I think the big issue is that when people come with their loved ones or an extended family to have a discussion about their diagnosis, is that we take time and we provide a lot of both written and other forms of information for the patients to digest. Because when you're sitting in the office, even when you're talking slowly and taking time with people, this is your diagnosis. This has an impact on you and your ability to process all that information at time. is quite difficult. And we almost encourage them to have other family members. There's usually a son or a daughter or a wife who's a little bit of a scribe. We're picking it in. I said, you brought in your extra ears. And that's actually a good idea, because you kind of don't necessarily remember every little piece of information that went through. So we try to spend time with everybody, sort of clear the playing field and help people understand where the options are in sort of simple, straightforward ways. Then also, present them with some information that they can digest in written form or other forms, and also hook them into some other, media resources that they could look up on their own, because there's just such a vast amount. There's tons of good information, sometimes not such good information, but we really direct people towards, strong quality sites where they can get more information on the disease as well.
Absolutely. And now, going off prostate, what are other urological issues today that are presented in some patient issues?
Sure. I mean, urology is the study of, the genitourinary system in men and the urinary system in women, and it really, even though it's a subspecialty, has its own universe of issues. I mean, we deal with voiding dysfunction. As I said, benign voiding dysfunction is a very big issue with folks, especially as they age. The whole area of urolithiasis, which is a fancy word saying kidney stone disease, and other bladder stone disease, afflicts a lot of folks, and it takes special expertise to handle this, and again, in a minimally invasive fashion. They were really the pioneers in our field in using tiny little pinholes and telescopes instead of big incisions for being able to treat these conditions. And, and then you deal with a whole host of other issues in general urology, things simple but very common issues like, and then some more specialized areas as well. We talked about male sexual dysfunction. There's a whole other universe of issues to take care of in pediatric areas as well. And surprisingly enough, it's not a contradiction in terms. Female urology, there are unique issues with female voiding disorders that deserve its own level of specialization as well.
Absolutely. So, Dr. Malkowicz, you work here for Penn Medicine. What distinguishes Penn Medicine from other urologic departments in the treatment of prostate cancer and other issues?
Well, I think that one big issue is the comprehensiveness that's available at Penn Medicine. As we were saying, with prostate cancer, we have folks here who are really pioneers at the very beginning of the new forms of open surgery for prostate cancer, and really made contributions in the literature over the past 2 decades in really defining how surgery plays a role in helping with this disease. But we just haven't stuck to one area and on a single note. We also have individuals here who are early adapters of the minimally invasive techniques. So in doing so, when people are considering these issues, they're looking at experts whose numbers really range in the thousands in terms of treatment with both modalities in that area. Radiation oncology here is a very, very capable and sophisticated and wonderful group of people to work with that who are experts and have the classic modalities like intensity modulated radiation therapy, but also things like the CyberKnife and also proton-based therapy, which is really a unique contribution that is available at this institution. So they really have the entire universe of available different treatments with radiation therapy. As I said, things are changing in medical oncology as well, and there are medical oncologists here who are uniquely attuned to thinking about and treating and advancing the forms of treatment that we have for advanced prostate cancer and disease that is a little bit beyond the local organ stage. And when you look at all those issues separately, that's pretty strong. I think the biggest issue is the integration of things, is that we all work together as a team. We meet with each other regularly. We work together as research colleagues together, and this close interaction and I think unity among the group really helps provide the optimal plans and outcomes for any individual patient.
Absolutely. Dr. Malkowicz, thank you so much for your participation and your knowledge and awareness for prostate cancer. We really appreciate you today.
Yeah.
And for Health and Wellness, my name is Ryan Griffo. Thank you for tuning in.